Thank you very much, Dr. Prakash and the whole Dr. Riku and the whole team of Global Hospital University. It's a great honor to be here with my colleague, Dr. Riju. Many times, epilepsy, there's a lot of confusion. Yeah, विदेशी कोही हुनुहुन्छ नेपाली नबुझ्ने हजुर okay, so I'll continue with you. So to understand epilepsy, sometimes you need to understand a different perspective of medical science itself. So there is two schools of thought in medical science. One is called the mechanist way of thinking of medicine, which is basically started by Democritus in Greek, and then the same school of thought by Newton, and then a very spiritualistic thought process, which is the father is the Socrates, a philosopher again from Greece, Athens, and which is followed by Einstein. So why I'm showing this picture is that if you look at the upper picture, this is the dust of an iron. So that is matter. But when you put a magnet below it, then it creates a pattern. Okay? But you don't see that energy, you don't see that field. So to understand epilepsy also, just looking at structures is not enough. You have to look at the energy behind quantum science rather than a materialistic science. And epilepsy is not a rare disease, and with many famous people I have depicted here had epilepsy in their life and became one of the most prominent figures in the world, like Leonardo da Vinci, which is, we all know, one of the greatest minds in the world that ever existed. And then there are many. And so talking about the basics of epilepsy, I don't want to go into details, but brain is an electrochemical structure. So there is a chemistry there going on, and there is electricity going on. And we all have electricity in our brain, and that's how we are functioning, okay? The electricity is so small that we have to have a special machine to magnify and then see it in EEG. So it is microvolt, 1,000 of 1 volt, okay? So it's in microvolt. So if there is an abnormal electrical signals that goes into brain, then that is epilepsy. So there is GABA on one side and glutamate and other structures, chemicals. So GABA and others are suppressing the brain not to create epilepsy, but the glutamate and this kind of chemicals, stimulate the brain to create epilepsy. So whenever we are right now, we are sitting here and we are having epilepsy in our brain. All of us, there is some epileptic focus that is being generated in all of our brain right now. And then that is being suppressed. So the red one is the place where the epilepsy is generated. And then the GABA goes there and then suppressed. So it's just like a penumbra of stroke. When you have a stroke, you have a penumbra. Okay? So that is an epileptic penumbra which suppressed, so it doesn't spread out. So you have a small epilepsy, you don't notice anything. And we are having that all the time. Just like we are having infection all the time. Okay, during our one day we have many infections in our body. Do you know we also have many cancer in our body? At least 10,000 cancer per day. And then we are suppressing. In the same way, our mechanism is suppressing. But then when that tilts off, then you have, it spreads to the whole of the body and then you get epilepsy, okay? So when you have an epilepsy for a long time, then it recruits another part of the brain and it creates that part also epileptic. So one part is epileptic, when it is firing all the time, there is something called nodes and connections, networks. So now the brain is more or less thoughts like a nodes, different nodes and connect nodes. So then you start spreading from 1, 2, 3, 4 and then many. So this is called kindling effect. So if you have a many epilepsy for a long time, then they become more and more epileptic and they become more and more difficult to treat. So our target for epilepsy treatment should be 0 seizure. That should be our target all the time. Okay? So when somebody has epilepsy, there are different things that is happening in the brain. So the most important part is the place from where the epilepsy starts. So it's called ictal onset zone, okay? Where seizure onset zone is the green one. So if you can find that place in the brain, then you know where it is coming from. And then it spread from one place to another, so that's the pathway. So you need to know where it is coming from and how it is spreading from one place to another. Besides that, there are different things. Most of the time, the MRI, the lesion that you see in the MRI in an epileptic patient may not be the site of seizure. So there are different things that we need to, I don't want to go into details of that, but just know that symptomatic zone, epileptic zone, and seizure onset zone, there are different zones in the body, okay? So I can leave this slide with Dr. Prakash, and then if you want, you can, so you don't need to copy. I just leave the whole thing here. So you can, download or see it again and again. And so this is Human Connectome project, which has now made all the small connections in the brain, and just like Human Genome Project. So this can show you a small connections from one place to another. So seizure also, when it starts from one place, it's spread in different pathways, and one of the biggest pathway is through the corpus callosum. So if you have a seizure here, then it spreads to the other side of the brain through the corpus callosum. That is one of the biggest, but there are many fibers, so you may have a seizure here, and then this may spread to the occipital lobe, and then you may have a symptomatology of occipital. So that's why I'm saying you need to know where it is coming from and how it is spreading. So that's the definition. I'm not very interested in the definition, so you can just, it should be studied. And it is not desynchronized, it is synchronized, okay? The concept is wrong. If you have a desynchronized wave in the brain, you will not create seizure. It has to be abnormally synchronized. It has to have a lot of brain neurons that should be firing together in an abnormal way. So it's a synchronized wave, okay? So the definition of epilepsy and definition of seizure is different. So all of us can have seizure in our lifetime. If we have a seizure for the first time, I always say you must investigate that person. And the best way to investigate is an EEG and an MRI, not a CT scan. If you do a CT scan, you will miss the lesion and you will falsely, tell the patient that, okay, you don't worry. And that's wrong. So you have to do a MRI. I'll talk about that later. But if you have 2 seizures, so let's say somebody had one seizure, you do a EEG, you do a MRI, everything is normal, then you don't need to treat that patient. Because many people, all of us, can have one seizure in our lifetime and it is not epilepsy. But if you have 2 seizures apart in 24 hours, then you never need to have epilepsy. 2 seizures 24 hours apart without propagation, then that is epilepsy, okay? Then you have to treat that patient. But investigation of all seizures. First seizure, because all seizures will have first seizure. Okay? So you may miss that tumor, you may miss that cavernoma, you may miss that AVM. So every seizure must be investigated. So there are different things which can cause seizure, but out of these, genetic is about 15% only. And right now we have just started looking at genetic epilepsy in our population. We don't have enough data to talk about it, but then it is not a big chunk, okay? In the past, neurocystic sarcosis was one of the commonest cause of epilepsy in Nepal. Now, surprisingly, within my lifetime, now the neurocystic sarcosis went down like this. And Professor Prakash is also nodding his head. Now we are seeing less and less of neurocystic sarcosis. Suddenly, that means our hygiene has improved. Okay? Our water hygiene, especially neurocystic sarcosis, is not coming by eating pork, by the way. It is coming from water, okay? So CNS infection or the other. And there are some factors which can trigger. So somebody don't sleep well, they can have seizure. Somebody who go to a flashy light like disco, it's a very good place for triggering seizure, and they will have seizure in the disco, you know. So, fever and sleeplessness, many things can trigger it, okay? So, since I'm a surgeon, I will be a little bit biased towards surgery, but then I will touch about anti-epileptic drug. So, whenever some patient comes to me, then I want to reconfirm that this is epilepsy and nothing else. Many times it's not epilepsy and they are taking anti-epileptic drug. So first you must confirm that this is epilepsy. This is most important. Many times you are treating non-epileptic patient with the epileptic drug for the rest of the life. Second is classify what is the type of seizure that you are looking at, whether it's a generalized, whether it's a focal, with generalization, different types. Huh? And then you start with one drug, simplest drug, first generation drug. It's always important, not the last generation, not two drugs, always one drug, and low dose, okay? Because they may be well controlled with low dose, okay? So if it is not responding to your treatment, then you have two choices. One is maybe you can stop it and give another medicine. Most of the time I do that. Because if this pathway is not working, I just stop that medicine and give up. But you can also add another drug for some kind of synergistic effect. But the second drug should have different mode of action, not the same mode of action. And so let's say phenytoin you gave, the patient did very well. After 3 years, the patient started having seizure. Same medicine, what's happening? You are confused. So this is because the liver is producing some kind of enzyme, and that is destroying the medicine, and it is not working. So these are liver enzyme inductors, and especially phenytoin is very notorious. So what I do is I stop phenytoin, I give drug holiday. I give it holiday for 3 months. So liver comes back, I restart. So during that 3 time, I give something else. Okay. So if some drug works very well, but suddenly it stops working, you stop that for 3 months and you restart another medicine. And more than 3 anti-epileptic drugs hardly works. I'll tell about this later. That's it. So people with epilepsy, if you give first medicine, 47% will be drug-free, seizure-free, and maybe 53% will be uncontrolled seizure. If you add another drug, you will add another 13%. If you add another drug, then you only add 1%, but you keep more complication, more side effect. So more than 2 drugs, max 3 drugs, that's it. And 4 or 5 drugs, it is never going to work. Okay? So then, if you give 2 appropriate anti-seizure medicine for more than 1 year, and if they are having 1 seizure still per month, then we define them as drug-resistant epilepsy or DRE. And that's where I'm more interested. So this is the definition of DRE. So these are like औषधले निको नहुने छानेर भन्दै हुन्छ बिरामी. So what is the percentage of DRE? DRE is 30% of all seizures will become DRE. It's a big number, I tell you. So these 30%, no matter how many medicines you give, they are not going to get cured. Not cured, but not even seizure control. If you don't treat epilepsy in childhood, early age, then these people, their life becomes less. They cannot go to school, they cannot get educated, maybe they cannot marry, their social life is destroyed, and actually their cognitive function also declines like this. And absolute mortality among general people and epileptic patients, if you compare, then epileptic patients, the chance of death becomes more. And probably you have heard the term called SUDEP, sudden unexpected death in epileptic patients. So they just, while sleeping, they have a seizure and they just die. So SUDEP is not rare. At least in my case, I have seen about 6 to 7 of my patients who have died while sleeping. And these are young people, and these have got, very, very frequent seizure and at night. These are very, very risky. So if you have a generalized seizure, young patient, we always say, sleep with somebody else. Don't sleep alone. And this SUDEP topic is so important that my son, who is in Czech Republic, he has been doing, when he was an MBBS doctor like you, he was doing study on SUDEP, and now he's doing PhD only on SUDEP because it's so important. So they die, so there's a real risk of death in epilepsy patients. So this is like a generalized tonic-clonic seizure. You can see that the patient is already having a seizure, bilateral synchronized, and that is shown in the video. So this is semiology, and that is EEG. Okay? So this is a generalized seizure where both of the brain is continuously, rapidly, So this is a seizure where the patient already has seizure, but then he is gradually turning his head towards the left side. So it's coming from the right side, and it takes about 10 to 15 seconds to So this is a different type of seizure. He's rotating towards the other side, and now it is a generalized seizure. Okay, so this is a focal seizure which has generalized into a tonic-clonic seizure. This is a temporal lobe epilepsy where the patient already had a seizure on the left side. I can see that. And if you look at her hand on the left side, she's feeling something, touching, searching behavior. Her partner or friend doesn't know that she already has seizure. Look at the amount of seizure that's happening in the brain. But there's no crying, there is no bilateral tonic-clonic. She can move about, she can walk, she can, maybe sometimes even drive. So this is a typical form of temporal lobe epilepsy. So why I want to show these 3 examples is that seizure can happen in different ways. This is not only seizure. You can just stop like this and then move. That is seizure, okay, which is called absence seizure. If you have a prolonged absence, then we call freezing. So somebody is like this, they freeze like this. So that's a temporal lobe epilepsy. So there are so many semiology signs, and that has got a lateralizing value. And we keep on studying this all the time. Dr. Rizzo and I am still studying, and there are so many, sometimes they have a nose weeping, sometimes they have a ictal vomiting. Okay? So many symptoms can lead to, oh, this patient is a... So I had one patient where she was driving and then suddenly somebody talks on her ear. Then she went to a psychiatrist and the psychiatrist treated her as schizophrenia because they thought that this is auditory hallucination. But this is typical epilepsy, okay? Temporal lobe, especially the posterior part. So you have to do it. So, and another thing that the young generation should get involved if you are interested in epilepsy is AI, and generally the software that deals with a lot of data. So we do a video EEG, sometimes we do video EEG for 6-7 days, So much of data, and you go crazy by reading all this EEG, page by page. So in this situation, there are many softwares. We use software called Persist, or there's a MedLab, which is a downloadable software. So some of you should get interested, because now the generation of eye reading EEG is going out. So we should start, you can even put it in some kind of AI software that is already existing. The one that I talked today, Cloudy. So this is our latest, very famous software, better than ChatGPT. So Cloudy, you can actually put that and then ask them to, analyze it for you, kind of thing. So you have to get involved in AI if you want to do epilepsy work. So now about MRI. When we say MRI, then there is a protocol for EEG epilepsy, which is called seizure protocol, which is given by ILAE. So it can be downloaded, and you should follow that protocols. So T1, how to take, T2, how to take, flare, diffuser weighted image, different type of protocols that you have to put. I just talked with Dr. Prakash, and then he said that it's already there in your institute. So you have to write, please give me a MRI seizure protocol, not regular MRI. Regular MRI is not enough. And don't talk about CT. CT will show nothing. So CT is not good. So this is a patient with, now we are talking about, you do a MRI comes out normal. And we are confused. What's going on? Is this really normal? So there is a lot of software where you can do a post-processing evaluation of those MRI that you get, and this also has to be done. So here you don't see anything much, but then when you do a post-processing like this, you put this data into a post-processing software, then you can very clearly see that there are lesions there. Okay, so MRI negative these days in a very good centers, they will say, have you done a post-processing? If you have done a post-processing and still the MRI is normal, then only that is labeled as normal. Okay? So this is something that you can do here right now, which is called MR spectroscopy, which evaluate the chemicals of within the brain, which we are doing in brain tumors and others, to evaluate whether it is a tumor or an infection, high grade, low grade kind of thing. So same thing in our institute, we continuously do this to compare the both sides of the hippocampus to see what the hippocampus contains. Okay, so this can be done anytime. Should start doing that. Another investigations that would be wonderful to have is a SPECT. So SPECT, you can do it. Do you have a SPECT here? No. Yeah, you have. So fantastic. If you have a SPECT, this is a fantastic armament that you have. So what you can do is you do if you have a SPECT within the institute, then you can do it within 8 hours after season, and then do another SPECT and then subtract. You put it into fusion to fuse the both image by computer fusion, and then you can have a hotspot like that. Okay. So if you have a PET, still better, but PET you cannot do epilepsy when the patient has seizure. It's most of the time not possible because the dye that you give in PETs come from India, so you don't have time to do that. So hot spot on SPECT, if you can find that, that's the place where the seizure is coming from. But this is not electricity, it is metabolism. So we just suspect that, oh, there's a lot of metabolism, so that must be the seizure point. Okay? Now, I talked about EEG, I talked about semiology or the symptom of the epilepsy, and I talked about the imaging. When these three things match together, then you say, okay, this patient was having this kind of seizure symptom, I did the EEG, which was showing in the same area, and I did an MRI, oh, it shows the same area. If these three things match, then you can say, okay, I can go and take that lesion out and the patient should be seizure free. Okay? So this should be concordant. Okay? By the way, we have about 90,000 patients with intractable seizure. Intractable seizure is 30%, so maybe 3 lakh people have epilepsy if you have 1% in our country. So 90,000. So if we can have at least 50%, we can detect something, then we can, at this present, there's 45,000 people who can be operated. So anybody can have dalbat by just operating on epilepsy. But then this figure has changed recently in our institute. I'll tell you later what has changed, okay? So 2001, I started epilepsy surgery from 2002. So this paper came out at 2001. My teacher in Japan said, oh, Basant, let's start epilepsy surgery in Nepal. I said, let's read this. And when I read this paper, the surgical group had a seizure freedom of 58%, whereas the medical group had 8%. Okay? So it is statistically significant. But I was not convinced because it was only 58% success. That means like tossing a coin. So I was reluctant to go on. But he said, don't worry, let's go. So actually he came and then helped me out in few cases initially. I always do that. I never practice on my patient. I do not learn from my patient. I learn from my gurus. This is medicine, okay? You kill 10 patients and you succeed from 11. That is not the way to go. Okay? You have to have some guru. They have knowledge, you learn from them. It's okay. Now I don't need him. For the last 15 years, he never came. We always, now we go to Japan to teach them now new things. So, this is prospective randomized, the biggest paper that ever came, and then this is the paper which rolled the dice for epilepsy surgery. So, these are the epilepsy surgery effect that is seen, and if you look at temporal lobe epilepsy on the left side, then the success rate is very, very high. So if you include these two, improve and free, then it is more than 80%. So if you can, by the way, our data is much better than this already. And there is a reason for that, I will just skip that. But if it is extratemporal, neocortical, extratemporal, the chances are little bit low. Okay? So if it is a temporal lobe epilepsy, our result is more than 90%. We have hardly had failure in temporal lobe epilepsy. There is no failure, zero failure, and there is zero death. And so if the seizure decreases by 50%, then we call it successful. But most of our patients in temporal lobe epilepsy are zero seizure. There is no seizure after surgery. So it is a fantastic place to start epilepsy surgery. This is my example, 2002. So that paper was in 2001. I did my first surgery in this gentleman on 2002. Maybe you were not born yet. So this patient had a typical complex partial seizure, temporal type, oromental automatism, looking around, walking around, déjà vu, surmise vu kind of thing, dreamy state. And he stopped going to school. He had many, many medicines. And if you look at his MRI, this is, at that time it was 0.35 test by MRI. And you can see there's a clear cord, medial temporal sclerosis, the hippocampus is atrophied on the right side. So, together with my teacher, we did this surgery. And this gentleman, he is off medicine. And then he said, no, I just want to have 100 milligram carbamazepine so that I can come to you. I said, you don't need anything, but he is taking, and every year he comes with his wife and then bring me some present, something he always bring, and his life has changed. He's a big businessman in Pokhara. He drives his own car. He was having 6 to 7 epilepsy a day. So this is the kind of life change that you can achieve. And this is not a solitary example. It's just that my first case, that's why I'm showing here. We have many, many patients like that. That's what we do in anterior temporal lobectomy. If it is right side, we do a 6 centimeter select temporal lobectomy. Together we take out the amygdala and we also take out the hippocampus. And tomorrow probably we will be demonstrating this on a cadaver on how to do this. So if somebody is interested, you can come. So another reason to start epilepsy surgery would be something like this. So these are called, epilepsy-associated brain tumors. The patient will come to you with seizure, not with brain tumors ICP, So they say, I have seizure. So if you take that out and don't cure the epilepsy, they are not happy. Just take that tumor out and the patient is still having epilepsy, they are not happy. And majority of time, that lesion is not the source of epilepsy. It is the brain around it. So you have to identify exactly where it is coming from. So these are very, very good initial starter. So here we did a functional MRI, and that is the hand area, and that's the leg area, okay? So we want to know where exactly is that, because it's a pretty eloquent area, so we want to avoid that area so that they don't have deficit on the hand or leg. And then what we do is we open up, that we, with the navigation, we trace down the tumor, and then we do intraoperative EEG, which is called ECOG, and we have leads like this. We are going to leave some of these leads with Dr. Prakash so that he can start doing that, and probably we can tell him how to interpret this. So it's a grade 4 echo seizure that we are seeing here. So we know exactly where it is coming from. So do many places like this. And that is the yellow is the central sulcus, anterior is the motor strip, and posterior is the sensory strip. So we know where the motor strip is. And after doing all this echo for some time, then we can pattern out where the epilepsy is coming from and where the tumor is. Okay? So you can take out the tumor and also the epileptic zone. So when you stimulate the motor cortex on hand intraoperatively, I'm sorry this video is not running, then you can see that the hand moves, and then you know exactly where the hand area is, okay? And then you can avoid that area. Okay, it's there. Or if you are not very sure, then you can, that's how it moves. Or you can actually do a awake surgery once the patient is, the craniotomy is finished. You can wake up the patient and ask them to move your hand and then start dissecting out, that is also possible, which can be done in any centers. So that's how we remove, okay? And this is after the surgery, then we know that the patient has a very silent brain around it. So on the table, we know we have cured this patient. We can go home and enjoy. Another case that is very, very good for epilepsy surgery is so-called trough attacks, okay? Where the patient will fall down like this, and then these people will have many injuries in their head, and then medicine don't work on them, so this is an intractable seizure. And if you split the brain into two halves and make right and left separate, and cut all the corpus callosum from genu to splenium, then this will stop completely. I've never ever seen a case where it didn't work. So, but then you need to cut everything. You cannot leave a small section also. And this is how we do corpus callosum, callosotomy. I'll skip that part. Now, this is probably my few remaining slides. This lady came to us with a complex partial seizure, again temporal type. Okay? And we don't know which type. And whenever she has seizure, she has some kind of stress, so she tries to kill herself. Okay? So, and she has attempted many suicide in her life, a lot of cuts in her hand, and she has actually tried to hang herself because her brain is pushing her to, kill herself. And if you look at the MRI, the temporal lobe looks, not very. We are not very sure which side the patient is having. Maybe left. We don't know. So now, in these days, now we have gone for the last 5 years. We have started a new technology where we can actually put small wires by robot or stereotaxy, whichever you want. Not the navigation. Navigation is not good enough. So you need to have either stereotaxy or you can have a robotic. So we are doing robotic these days. So you can put these small wires into wherever you suspect that area and then study. This is called SEEG or stereotactic EEG. So this is how we put. These days we are doing with frame. Now we are doing without frame with the robot. And then these are the stereotactic wires that we put in the brain. So we want to know where the seizure is coming from. Seizure onset zone, we want to know. Okay? And then very nicely you can see that the amygdala is pretty silent. Hippocampus head is also silent, but the hippocampus body is constantly firing. Constantly firing. So we have picked up out of those channels. So we have many channels in the hippocampus body, and we know exactly the second channel is the one which is firing. So in the hippocampus body, where the second channel, there are many channels. The second channel is the one where the epilepsy is coming from. So we have detected exactly where it is. So in this case, actually, we operated and take that out and then she become completely seizure free. But now we have moved on. And now we are thinking of doing a laser burning of that area so that you don't have to do anything else. You don't even have to operate. So the same stereotactic probe can generate some heat and burn that area so that she becomes seizure free just by one small purpose, okay? So this is after surgery. Again, we always do EKG in all our epilepsy patients just to confirm ourselves, reconfirm. This is a hypothalamic hamartoma. We have 5 cases like this in our series, and here the children will have gelastatic seizure. The children will laugh for no reason.